And we're good to go. Okay, so this is just, you can get these objectives off of the Moodle page or out of your syllabus, same thing. If it helps you to see them alongside of here, I tend to put them in my lectures. All right, so seizure disorders, what are we going to talk about? All we know about the brain, it's so enigmatic. There's so much we don't know. And one of the things we don't know about the brain is to understand all the electrical activity and all the problems that happen and how this is affected. And so we struggle to control it. We've come a long, long way, but we struggle to control it. When someone has a seizure, it doesn't mean they have epilepsy. That's kind of the way outside people think. You know, anybody who's outside of healthcare, they think they read it in the Reader's Digest. It's what they always believe. They don't know who told them. That's what they think. So that's that's what you're up against sometimes, is their misunderstandings of what's behind their own illness. So a lot of teaching comes into what we do. It's usually symptomatic of something else. Maybe it is something horrible. You have a brain tumor or an aneurysm or something else that's irritating your brain. But it can be that your electrolytes are out of whack, that you've been really sick with a sepsis and you're just, your electrolytes, we just can't get you straight with your fluids. It could be someone who's really hypoxic, not enough oxygen getting up to the brain's not going to be happy. Someone who drops a blood sugar, someone who drops a blood pressure. Sometimes you see that in the hospital where somebody gets up and they get orthostatic and they drop their blood pressure and they seize. Not enough blood getting to the brain makes it a little testy. You've seen it with your withdrawal patients, probably in 155. Any number of things we'll talk about. Most of the content we cover this semester could result in someone having a seizure for one reason or another. So it's not just the brain, but the brain is sensitive and it likes to be the way it is and it likes everything to work well. And when it doesn't, it lets you know. Okay, so seizure disorders. Now let's talk about epilepsy. This is the one seizure disorder we know of. And these, we don't test you on statistics, but we bring them forward so you understand the populace you're dealing with, you have some insight. So Lewis is telling us about 2.2 million people have it. And the Lewis book has been out now a couple of years, and on average, textbooks are about 4 years old before publication. So I doubt the number is that low. It's probably more than that. But most of our skewed data in terms of numbers of what people have and don't have is related to the fact that they don't report. So unless we have someone who's capturing people in their care group, in their practice, who have these things, or you go to a seizure center where they keep track of you, we don't always know. We do know it's more male than female, which kind of takes the hormone shifting out of it. The highest new onset is not surprising, really. It's over 60. So while we will find people with epilepsy usually earlier, we see something in childhood or early adulthood or something, if it's true epilepsy. We have the other mitigating factors that interfere with it once they're over 60. They have strokes and they have other reasons to make the brain less tolerable to the irritability, cancers, things like that. So it just depends. I mean, that's why that group is over 60, even though you would think if it's something they have, a condition they have, they should have had it earlier. They likely did, it's just more exacerbated now. More common in the African American community as a demographic of race. Also, another group is those who are disadvantaged, so people who are poor or people who are uneducated. And really where that speaks to all of this is historically we don't know with the African American population, other than they also tend to run hypertensive. They also have an increased number of strokes. So does that have an influence? I don't know. It could skew data as a demographic. Disadvantaged may not seek out medical care, may not know where to find it, may not have it available, don't recognize what they have is something serious. If they've always lived with it, they just might think it's the way it is. Someone in their family had it, whatever, they live with it. Alzheimer's, strokes, obviously anything to the brain that alters it physiologically could be an issue. But certainly a parent with epilepsy puts you at higher risk. Now there's no gene, but we do find that if your parent has epilepsy, the children are great at risk for having it, whether it's some kind of gene variant or something we don't know. All right, so causes by age, 0 to 6, it's usually congenital. If you are 2 days old and you're seizing, something's wrong. You have some issue with your brain, compression of your fontanelles, something developmental. Maybe you're so premature that you're seizing because your nerve endings aren't finite. All the way up to about 6 months, that's typically what we're seeing is something you had with you when you were born. 2 to 20, it's now birth injury still. It could be traumas because now kids are up and walking, trying things, falling over. If you've ever had a toddler around you or people or babies that are just gaining their sea legs, they bang into coffee tables, they go up. Look at the horrible traumas when they go in those little things they ride around in when they're trying to get leg strength, you know, and those little cars, sometimes they'll take them right down a flight of stairs. So we start experiencing trauma with kids that age. And there's always the question of genetics. If a parent has epilepsy, why are we starting to see it in kids young? Because it's probably some type of inherited trait, familial trait, something, but still no gene to define. 20 to 30, we're talking structural. Not that we don't see brain tumors prior to that, you can, but also the traumas. They're in that whole demographic, they're into extreme sports even. They're doing like crazy things with their friends, you know, at the beach in the summer or who knows what. So even skiing, even things that they suddenly have money to do maybe in their 20s and 30s. You know, they're going to have more traumas and things like that, car accidents, brain tumors, vascular disease. Now, what they mean by vascular disease is not so much we're looking at atherosclerotic plaque or something, but more like AV malformations. So, you know, we could all have, God forbid, but we could all have an AV malformation and not know it. Your arteries and your veins, where they come together, is malformed. And it's usually bubbly and not formed well. And you may do okay most of your growing up, but it might be what kills you. If it suddenly blows and that's it, you're bleeding into your head and you drop and you're dead. And they do a postmortem on you and they'll say, wow, they had an AV malformation. Well, there's no way for us to know that. One demographic you tend to see it in is people with Downs or people that are severely cognitively and physically impaired, because you probably learned in peds that if you have a child born with a lot of anomalies, if we can see one anomaly, there's likely others. So who's to say when we get inside the brain what's in there? And we don't go in and look, so we don't know. But that's often how your Downs or your severely mentally handicapped people will die, is usually from an AV malformation. So then over 50, again, we're looking at the CVAs and maybe early onset dementias and mets to the brain from another disease. About 30% they estimate, I don't know where that number has gone, are idiopathic. Who knows why people are having it, you know? Could we guess? I mean, if we have you in the hospital and we're doing labs and things, we're assessing you, we can probably say, yeah, your electrolytes were skewed, you were, you know, septic, you were this, you were that, we couldn't keep your BP up, whatever it was. But a lot of times we just don't know. The theories are genetics, maybe, they keep looking, maybe they'll find a gene someday, but nothing so far. The other thing is people just tend to have a predisposition towards seizures. And what they mean by that is, you know, why is it in a kindergarten class full of kids, why is it that Johnny is the same age as Michael, and Johnny, when he has a fever of 101, has a febrile seizure, and Johnny can be 103 and not seize? So simple observations like that lead people to believe, what is the predisposition? Now, if there's any. Now, when they have gone in and looked in people's brains after death, obviously, to people who, you know, have allowed them to look at their brains, who have suffered from epilepsy or whatever all their life, and they go in, they find a lot of gliosis. Gliosis is neuronal scarring. So do you have, it's chicken or the egg now? Because we don't crawl into people's brains to see them, to see people without this history of seizures. We don't know if they have as much gliosis. Do they have the gliosis because they've had seizures all their life and it's scarred? Or were they born with that scarring and that predisposed them to having seizures? So that's where the studies are going. Astrocytes are another thought that's gaining a lot of traction because they release glutamate, which triggers firing. And so do some people have too much glutamate? Is there a way to measure it? How do we treat it? That kind of thing, okay? All right, so So what do you see? Well, there's several phases of seizures. We talked about how we borrow some of these for the headaches last time, right? So the first phase they talk about is prodromal. This is the premonitory. Now, it's a premonition. It's something telling you it's coming. And like I said with the headaches last week, a lot of people aren't tuned into it. So, you know, they're physical signs, and they can happen hours to days ahead of a seizure. And if we can get people to hone in on them and pay attention to these physical signs, we can preemptively treat a seizure. We can give them something, a little extra dose of something, so they don't have a seizure. Because when you have a seizure, you're frying your nerve endings. You're frying your neurons in your brain. So how many of them can you take? So prodromal phases are important. And some people have them. They'll be on a eating binge. They have hyperactivity. They have, you know, cravings that they're irritable, super, super irritable. And it's out of their character. So that's something that we try and get people to focus on. Is there anything like that you can think of? The oral phase is, we've talked with headaches that we borrowed this part from seizures also. These are the sensory signs. So what's your aura? You know, what's telling you something's about to happen? And I spoke about last week, the buzzing in the ear that no one else hears, or a high-pitched tone, or a ringing of chimes, and there's no chimes around you. It's you having your own concert. It's your sound you're hearing. It's any of the senses. It can be something acrid you smell, or something super sweet, or something, but there's nothing around you causing a smell like that. And you're the one saying to people, do you smell that? And nobody smells it. So it's a sensory signal. One of your sensory nerves is telling you something is impending. A motor tingling. Sometimes they just feel like something's like an unnerving feeling on the back of their neck, or down their arm is just like, you know, little patters of rain or something, and they know nothing's there. They'll look at their hand every time. But if they describe something like that to you, it's an aura. So we're trying to get them to hone in on that. The next phase is called the ictal phase. And this is when someone is actively seizing. Ictus is the Latin word for blow or stroke. And apparently in Roman times, they would whack somebody in the head with those gladiator things they did. And they equated the blow in the head with the person having the seizure, which, yeah, we get it, right? So, you know, a club with spikes on the end of it will do it, you know? So anyway, it's the active portion of someone physically having a seizure. That's the ictal phase. So after it, it's called post-ictal. And in a post-ictal phase, people are good for nothing. The brain has short-circuited with a seizure, and it's really hard to rouse them sometimes. You can usually get them to open their eyes and whatnot, sometimes not even that. So you have to be familiar with these phases. A, the first two to help people identify them, and B, the next two to see what's happening to this person during the phase, the ictal phase, and then monitoring them post-ictal, make sure they're breathing and they're okay. So we classify seizures generally as generalized seizures or partial seizures. And the symptoms are going to depend on what kind the person has. So let's look at generalized. Now, not difficult to understand. It's the general brain. Both sides of the brain are involved. A loss of consciousness in seconds to minutes. And tonic-clonic seizures are the main generalized seizure. They used to be called a grand mal seizure, which is French for big bad. And this is a big bad seizure. I mean, the brain, both sides, is just short-circuiting. They get cyanotic. They hypersalivate because they're not able to swallow. They're incontinent of urine. So they lose this consciousness. There's a tonic phase first where they stiffen, and then they're clonic, and they're having all the muscle tremors. Now, when people report seizures, the variance we're going to see in the next couple of slides is largely because they haven't seen the whole seizure, right? So let's say, you know, Gladys and Joe are living at home, and Joe tends to have seizures. So Gladys looks and sees that he's got a prodrome or something, or he's got a more likely an aura minutes before, and he's telling her about it, and she's thinking, oh my God, he's going to have a seizure. She runs to the phone to call the doctor. She misses that tonic phase. She comes back in, and he's seizing in a clonic phase. She'll tell the doctor he doesn't have that first phase where he's stiff. He just shakes. And we can't assume anything because we're not there to see it. You only report what you see. So if somebody calls out and says, my father's having a seizure, and you go in and you just see him in a postictal phase, we know if he's postictal, it's a generalized seizure, but can we say that he had the tonic and clonic phase? We can't. So all you can report to the doctor or in your notes is, wife said her husband was seizing upon entering the room, the patient was laying still, and this and that. You can only talk about what you see. And that leads to a lot of the variance in what we're going to look at. All right, so typical absent seizures are also a generalized seizure. Now, typical absent seizures are called traditionally petit mal seizures. You'll hear that referred to. Even on neuro units, they don't all say, they say typical absent seizure. Grand mal, petit mal is a very common term still used. So you see them more with your pre-adolescent kids, but you don't have to. And there's, if we capture somebody on an EEG, which is near impossible, they would have to be in a neuro ICU or in a seizure center getting studies done with electrodes all over their heads for us to capture it. I mean, you can't possibly get them on and do it in enough time. The person's shaking to death. But if we can capture it, it's got a very distinct wave pattern to it, which lets them concretely know that this is a petit mal seizure. Usually the person has a brief staring episode. I mean, they're just staring off into space, and you could blink to threat and they won't react. You can call their name, they won't react. And complex absent seizures can have other physical activity like blinking and chewing or hand movements. Sometimes their hand will just shake, or they look like they're chewing on gristle, or sometimes just biting their teeth up and down. There's some repetitive motion to it. They find they're precipitated by flashing lights, which is where the driving thing comes into people that have epilepsy, whether or not they can drive. So think of yourself on 77 or 85. I don't remember what those median strips look like on either highway, but surely you've been on a road where they have a bunch of metal bars, probably 3 or 4 feet off the ground, I don't even know, and they're bars that go this way and they have a band across the top. And when you're on those highways at night, your headlights are on so you can see the other side of headlights are coming towards you. What it looks like to you is strobe lights, because as the lights pass in between those poles, you're not catching just the glare of constant light. You get that intermittent light. Something like that can trip seizures in people who are prone to seize. So what else? Being in a club with strobe lights, or being someplace where there's just, you know, celebrations and all kinds of sensory input like that. Hyperventilation is another one. So when sometimes the kids in school, when they were small, would run around the schoolyard at recess and come in and just be staring out the window. And teachers would say for years, you know, I have a daydreamer in the class. They just look out the window and daydream. Is it that? Or is it, did all this hyperventilation running around and all trip something in this child? Who knows, you know? All we can do is acknowledge behavior. So an atypical, of course, if we're going to have a typical, this is medicine. We're going to make it more complex and say atypical. This is still considered a generalized seizure because there's both sides of the brain involved. So they might have a brief warning period. Like, and I had a girl in my dormitory. I was an RA in college, and I had this girl in my dormitory who knew she would have seizures. And sometimes it was just minutes before she would say, oh no, I'm gonna, and then she'd start seizing. Or she'd have one of these really weird episodes. So sometimes there's this brief warning period that something's not right. I had a patient on 7 Tower once say to my precepting student, I'm not right, what's happening? And then she went off into this, you know, staring off state and all of this. And I said to her, let's go back to your seizures. Could be something like a seizure. We were in the room, we saw it. So very odd behavior. She was moving in all kinds of directions, like she didn't have control over it. And then she would just stare. And the student is like, she's not breathing, she's not doing anything. I said, well, she's still sitting up. So she is breathing, look at her chest, you know. And so we were assessing the situation. And afterwards, when all of a sudden she stopped staring and looked, she was like, I don't know where I am. Where are we? Who are you? I mean, she had no clue about anything. And we got outside the room and the student said to me, do patients do this really? Like, she was so put off guard. And I said, patients can do anything. I mean, nobody's predictable. We have no idea. You can only deal with what's in front of you at the time. So it could have been some, I'm not a neurologist, but what could we report? We reported what we saw. And maybe it lines up with something someone else has seen or something they were suspecting. The other generalized seizures, which really are just, I think, pieces of seizures, are people who just have jerking and twitching and nothing else, or people who have a sudden lack of tone. They call them, this atonic seizure where, boom, they just collapse and they're on the floor. And you risk injury because they're not guarding their fall. We don't know what's around them. They just drop. The tonic, some people say they just stiffen and that's it. Well, after you saw them stiffening, what did you do? I ran for help. Okay, well, the clonic phase might have been coming, but you can't tell people in their own homes they're trying to do what they can, So was it really just a tonic phase? Neurologists tend to believe no. But if that's what's reported, we're going to keep all of this as separate things and representing generalized seizures. So, okay. So focal seizures, now this is different. Focal seizures are partial seizures, and these are a very specific foci in the cortex. So in your brain, they're typically just sensory. So it can be motor, it can be cognitive, but what you'll see likely is probably a sensory bend to it, a simple one. And the symptoms are going to depend on what area. So it becomes very important that your documentation is accurate, because if they know this person is in with a neurological problem and we're watching them, we need accurate data, So they divide focal seizures into simple and complex, of course. And the simple is very simple. So it's the patient is conscious, but they just have an emotional lability about them. They have, maybe they're crying, they're suddenly, irritated, they're having this response that everyone's like, whoa, 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 you were just fine. What's the matter? And they're just having this, they can't describe it. They're just, and they have odd sensations, and they'll tell you, my shoulder is weird, or my arm is weird, or my leg is numb, or they're having some kind of neurological event, and it's just really hard to corral it and contain what it is. They think it's probably a focal seizure, and it's just a very simple level. It's not enough to cause a generalized seizure and make the brain go crazy, just enough, neurological irritation that this is what we're seeing. Then you have the complex focal. So this is where someone's eyes are open, but they cannot interact with you. So when they say a clouding or a loss of consciousness, they don't really feel there's a loss of consciousness in most cases. How could this person maintain their body situation? They're sitting, people I've seen like this are sitting upright in a chair, and they're not slumping over the table. It's very hard to imagine someone has lost consciousness and can maintain their body stature. So that's where that comes in. But the fact that they can't react to you and they can't interact with you, they don't hear a command, there's nothing. Even after the episode, they can't recall it to you. So it's not like they were there and just couldn't communicate with you. They don't know what you're talking about. So there's a clouding. And then there's confusion. And sometimes, like when I've been with students and without, and I've seen patients like this, they're like, why are we in a gas station? I didn't think we were in a gas station. All of a sudden they come up with something. Well, clearly in a patient room, we're not. Like there's nothing in there giving them a subtle hint that we're in a gas station. But they're suddenly confused and they don't know. And I'll say, oh, Mrs. So-and-so, look at me, talk to me. And she'll turn and say, who's Mrs. So-and-so? Like they don't know themselves, they don't know anything. And then the ones I have had usually don't talk to me again. They're just off in space. So they might have an automatism. What I've seen them do is like, they'll bite their teeth together, which could be spasm, but they do this little sound with it. Or they do up, 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 up. They do something repeatedly. Sometimes it's their hands again. Sometimes their foot is banging. There's something else that goes on. And then it all just kind of passes. And then afterwards, when you're talking to them, they have no clue. They don't remember you walking in the room. I mean, not just the episode, probably several minutes before that. They don't remember any of it. And they look around the room and they think it looks like a hospital. And then all of a sudden, oh yeah, I was in the hospital. You know, it comes back to them, but not the episode, not the episode. Now, it's not a tonic-clonic, but something's going on neurologically. So they call them complex focal seizures.
Hey, Jane, quick question.
Yeah.
So the focal seizures are not a part of the generalized seizures category group, right?
Right.
Okay. Right. Just want to make sure. Thank you.
Focal are really specific focus in the brain. The generalized seizures, which are worse, are the entire brain is reacting. Yeah.
Okay, thank you.
Yeah. Okay, so secondary generalized seizure, of course, we have to put another layer on things. So some focal seizures, they think, do evolve into a tonic-clonic seizure, which is not that hard to understand, because whatever irritability, even if it's a single focus, your brain is irritable. Something's making you behave in a rewired way. You know, something isn't right. So in some people, is that enough aberrant activity that it trips you to have a generalized seizure? Yes, that's the thinking. So they think that tonic-clonic seizures that go back as far as beginning with auras, because auras are sensory signals, might even be partial focal seizures that evolve, and they call that a secondary seizure. So there are, when people came through with this theory, I'm sorry, this is Janie McCluskey. Janie, of all people, you know I'm in class. Sorry. So in some people, they're saying that's what it is. It's enough, you know, in the brain, enough, something's going wrong to trip the whole thing. And it could be, since we're looking at sensory stuff, that's the trip of it. The focal seizure part might go unnoticed. If you have someone who has generalized seizures and they're not aware of their auras, it could be this, but they're not aware of it, so they don't have an aura, so they can't report it. So that part could go completely unnoticed. What we do find with secondary generalized seizures that gives us a clue is from this Dr. Todd, who came up with this. I think he was Scottish years ago. He said, there's certain post-ictal people. Now, after a tonic-clonic seizure, they're post-ictal, they're wiped. And after that, they have a residual weakness of some part of the brain, some specific something, like their weakness in the arm, or their speech is impaired, or something. And of course, you see a patient like that in the hospital, or you had that as a clinical student, you'd come running out to me as a clinical instructor and say, I think my patient's had a stroke. So are they going to work those people up? Yes. They're not going to see that you suddenly have no use of your arm, and they're not going to do something about it. They're going to scan you for bleeds and this and that. What they find is that there is no bleed, and that within 48 hours it's resolved. So they think you started with some specific foci that was just out of whack. And from that section of the brain, not only did it trip this big seizure, but that's what's left from that specific focus, is that your speech, your sight, you temporarily don't have it until the body gets back on track. So that's what they're calling a secondary seizure. And that's how they kind of validate it. Does the person have residual weakness? Now, not everybody with a tonic-clonic seizure will have a secondary seizure. That's not what it is. If they don't report an aura, maybe they don't have one. Maybe they're just not aware of it, whatever. But they also won't have the residual weakness. They'll just have tonic-clonics, and that's it. So that's how we separate. Psychogenic seizures you may have learned about in behavioral. It's very, very sad. It's usually, we see them in people who have been emotionally abused or physically abused as children, and it's they're not seizing at all. It's that they manifest themselves as they are. I have had people having these psychogenic seizures, and you would swear they're in an actual seizure. I mean, really, they're getting circumoral cyanosis, they're frothing, they're jerking all over the place, they're incontinent, and we're running around doing all our nurse things. And, you know, the first time it happens, we're like, wow, you know, what's going on here? This patient has no history of seizures, whatever. If they put them on an EEG, the next time it happens, there's nothing on the EEG, nothing. And another time they'll seize, and we're in that neuro ICU room and we're doing all our things, and the doctor will look at the 24-hour continuous tracing and just be like, nothing. So we know that it's psych in orientation. All right, so what are the complications of seizures? Status epilepticus, bad news. Status epilepticus is continued seizure activity. It's at least a rapid recurrence, greater than 5 minutes, they're still seizing. Maybe not continuous, one continuous seizure, they'd probably be dead, but they have a seizure, it stops, they have another one, it stops, they have another one. I mean, you just can't stop them. And the danger is, think about it, when your brain is seizing, you're frying your neurons. Your body functions are, non-functioning. You can't swallow, you're collecting all the saliva in your mouth. You're not breathing. Now, for every time someone writes an article about how much breathing is actually done during a seizure, we can't find proof. But then there's the other side of researchers who say, but if we don't have proof, there isn't. Is there? Those people. And so the thing is, the patients get so blue if you see them. And if you see someone with status epilepticus, God, I mean, they just don't, they recover and they have another. It stops, they have another. So for someone who's not breathing during a seizure, these people end up with anoxic brain. I mean, it's just awful. And I've seen people from a respiratory arrest in an unrelenting seizure become a cardiac arrest. And we're wondering how much anoxia there now. Now we're not even circulating. I mean, nothing's happening. So it's a dangerous thing to have someone have a seizure and not be able to understand it and try and control it. So it's a neurological emergency, right? Realize the risk here. The big danger, and we see it in the ED, somebody comes into the ED and they're having a seizure. They're going to give them, a benzo. They're going to give them Ativan or Valium or something to make the seizing stop, because can we get a line in you? No. Can we do anything to you when you're shaking and jerking? Not so much. So they're going to give them something like that. And that's fine. The outside stops shaking, but it doesn't mean the brain stops seizing. You can still be having what they call subclinical seizures, which means your brain is still frying itself, even if we're not seeing it now because of the benzo. So you're still doing damage to the brain, which is why, sedation is never enough. Sedate them, yes. And people who work in the ED will say, that's the only thing they give them is sedation. That's the only thing, but you don't see past that either. Once they're out of the ED and in an ICU, they need an anticonvulsant, because an anticonvulsant will stop the next seizure from happening. We might have to change doses. We might have to give you a second dose, third dose, whatever we have to do. But sedation alone is not enough. It's not addressing the excitability in the brain cell from the drugs, some of which we've talked about already. So that's important. All right. Epileptics have a mortality that's 2 to 3 times greater than people who are non-epileptic. And I think it's kind of a misnomer. They call it SUDEP, a sudden unexpected death from epilepsy. Is it unexpected, really? Do we not know when someone has a seizure and dies from it, what's happening? We know they're not breathing. A respiratory arrest is going to cause a cardiac arrest if you can't intervene and do something about this. So it's not unexpected that way. What they mean is it's unexpected from the standpoint, if you've been diagnosed as epileptic, you should be managed as such. So you should be on something that controls your seizures so you're not finding yourself dead from it. That's really what that's all about. Okay, so what's the diagnostics? Well, accurate description and history. It doesn't seem real fancy, right? You're like, wow, accurate description, that's the diagnostic? Yeah, we got to go by what people see when you're having the seizure to try and understand what we're looking like. The other thing is, we can get an EEG. You can't get it when someone's seizing. We have to put very precise electrodes all over the head, and someone's banging all around, it's not happening. So, but if someone's admitted like that, we put them in the neuro ICU, then they can be on 24-hour EEG monitoring. And so all you have to do is look at your screen and see what's happening. They like an EEG within 24 hours as protocol, within 24 hours of a seizure. Nothing's really going to show on it. Not most times it doesn't. And it's not that it's worthless. I mean, if somebody has a tumor or something that's always causing low-grade irritability, that might come up. We might see that. And it might take us in a different bend to maybe, scan the head or do something different, or, do more diagnostics one way than another if we think it's tumor related or aneurysm related or something. But otherwise, just to do it and trace them while they're not seizing, doesn't really help us. So they do 24-hour EEG monitoring in the neuro ICUs, and with good reason. While they're in there, if they have been seizing and they've had long, prolonged seizures, let's have them on a monitor when one hits, and let's see what happens. If you have some pathology causing it, it's going to come back, because unless we remove the pathology, if that's the source of your seizing, you're going to have it again if we can't remove it. So, all right. So then there's the MEG. We don't have a MEG. Not many hospitals do. I think there's 19 in the country. This is a magnetoencephalography. And they use this thing called a squid. You don't get tested on this. It's just because you're being exposed to theory, you have to understand what we can do. But they put this squid, this super quantum interference device on your head, and it maps out magnetic and electrical fields on the brain. So if someone in your life is having trouble with seizures or has had seizures and they're usually poorly controlled and they have breakthroughs, you should be at a seizure center. It really, where they do all this cutting edge work, it really can improve somebody's quality of life. Otherwise, we're doing chem panels and liver function, and we're looking for other metabolic causes. Check your kidneys, your liver, your, everything. Structural lesions could always be a brain tumor. They probably scan your brain. They can do PETs and magnetic resonance spectroscopies and all kinds of things, whatever the hospital where you are does. But it's the accuracy of details. What we think we're dealing with becomes most important. All right, so most seizures are self-limiting, thank God. And people have them and then they're over. And then you need to seek medical care. Patients do note the occurrence. They might not be aware of it afterwards, but people around them should be noting occurrence. Sometimes patients who tend to have generalized seizures and have tonic-clonics at home will tell you, I was doing good. I didn't think I was having a seizure, but yesterday I woke up on the floor in a puddle of urine. So they know. And it behooves them to report it. We need to teach them to be compliant and tell us when they're having breakthrough. So they're not in a car driving when they have a seizure, kill themselves and somebody else, or, they're not going up a flight of stairs and end up dying from a brain hemorrhage then because they go down and crack their head on the step. So, medical care is always required if it's the first episode. If you or your loved ones or your patient has never had a seizure and has one, they need medical care because something tripped it, and let's see if we can't figure out what it is. If there's bodily injury, they've got to seek help. Now, we had a case come to us at Maine. My poor students, I have them places, they see everything. And this poor lady was making a change of flight. And when you fly into one town and you're not on the same airline, how you have to go collect your baggage, come back up, recheck in again, go through the gates. And so she arrived in Charlotte. She was going downstairs to baggage. And out of the blue, on the escalator with a full flight of people, she has a seizure. So this poor soul goes down, and she's going down the escalator, and at the bottom, she's on her back on the steps and just riding down. People are jumping over her with bags and carry-ons and whatnot. They said it was a mess. People were freaking. They didn't know what to do. Nobody is pushing the button to stop the escalator. So this woman's hair gets caught in the bottom step of the escalator. And now the steps are coming down and she's getting these things in her head. And people are just screaming and yelling and whatever. So some agent down there, baggage agent, calls somebody and got the paramedics and somebody, the security guy, I think it was, came over and shut the button. And so here she is, and people coming down the escalator, still jumping over, people in a crowd, what are they gonna do? So anyway, she comes down and they get her, they take her to the hospital. So the last thing she remembers is she's getting off the flight in Charlotte and she's coming down and, a seizure hits and she remembers nothing else. So she wakes up in the ICU at Maine and she's like, oh, my head, what's happening? And, and it wasn't the fall that caused the seizure because people saw that she was limp before she fell. Now, was she limp from not eating, blood pressure? Who knows? We're guessing. But going by the description of what they saw at the time is all we had. But she comes in and look at the damage she had. So bodily injury always is a requirement to go in. If they've had one of those atonics where people are reporting they just dropped, people break arms and shoulders and crack their heads doing that. They have to come see somebody. If it's prolonged or recurrent. If you've ever seen anyone in a seizure, it always looks like it's taking forever to get over, and it's not. So as nurses, we know, let's look at my watch. My patient's seizing, what kind of time am I looking at? And I'm watching my patient. Are they cyanotic? Are they frothing? Are they, jerking around? Are their arms okay? Are they are they on someplace where they're banging their head? If I was back in the old building, which probably none of you were there were steps in the auditorium, 3 or 4 maybe steps up to where we used to teach from. And if I used to tell the class, if I start seizing on these steps, pull me off the step so that I'm not constantly banging my head into the back of the step. Not that I had seizure disorder, but I was giving them an example. So, shift people like that, but we don't go moving people either. We just protect them, try and keep them safe. Okay. Now, what else? Therapy. A cure is not possible. We don't have enough answers about seizures. Our hope is that we can control people through medication, and every day there's new meds, so it gets more hopeful. So most people will need a combination. What are these meds going to do? We've talked about them last week. If they decrease excitability, if they balance out chemicals, they all have a little bit of mode of difference, but the aim is the same thing. If they're going to decrease excitability, it's going to lessen your chances of having a seizure. That much we know, so we're going to try that first. Now, you might need combination therapy. Maybe this works, but every now and then you get a breakthrough, they might put you on a little bit of something else. But if this is what works for you, then take it. Better than frying your brain and putting your body at risk. So you gotta take it. The thing is, they always want the best control, the least side effects. Anything that is decreasing excitability in the brain is going to make you sleepy and lethargic. And just like people who take some of these meds for psych issues, what don't psych patients like about it? They always feel sleepy. They sit in a chair and they want to fall asleep because their brain is sedated. In whatever mechanism we're using, that's the effect they feel. The same thing happens with these people. So they'll say, I haven't had a seizure in a month and I'm tired all the time, so I think I'm done. And they come off of it and they have seizures. So it's important to listen to people. When they tell you they're having this reaction, that it's just, I'm so snowed, I can't work, I can't keep up with the conversation, I can't watch a movie front to back, I can't read a book, I fall asleep. Those meds can be tweaked. Let's try something else. We have enough of these varieties, we could try something else. If someone still has seizures, then we have to think of a couple of things. Are they really compliant? And with some drugs, most drugs, we can go to drug levels and see. Dilantin, they check drug levels all the time, and they can tell if you're taking it or not. But if they are compliant and they're still having these issues or still having breakthrough seizures, then we got to remix the drugs. They have to give them a different combination. It's not working. That's not the goal. Now, there's more drugs in the pipeline now at the FDA, which is encouraging. And they supposedly have less side effects, but they do a good job. And, our FDA trials, by and large, take about 10 years. So they're coming. It'll be a while. You'll see it in your practice. All right, so what medications are we talking about? We've seen them last week. Phenytoin we didn't see. This is Dilantin. This is the prototype of seizure drugs. It's been around forever. And what do we know about it? It's cheap, so people can afford it. It's available PO or IV, so it's good for the person taking it every day at home. It's good for us in an emergency situation. I can throw it up the IV. What else? It's good for, it doesn't work well with D5. Don't mix it in a D5 bag. If you see a patient who has any kind of an IV with D5 in it, you'll find nurses, when they have to give it, hang a separate line that's normal saline, because it will cause the crystallization of the drug. That's the reaction it has. When you have a crystallized line, everyone's like, oh, bummer, it's clogged. No, what you have to think is there's a bigger bummer than that. If any of those crystallizations get into the bloodstream, now you have emboli. And if you have someone who's prone to, collecting that stuff anyway, because they have atherosclerosis, or they have whatever, or they've had surgery, and they're at risk anyway for emboli, then that's what it's going to get. And it's often your IV. So think ahead of time. You can't put D5 there. What else? Otherwise, it's a pretty good drug. It's no grapefruit juice. Just about everything I teach, I say no grapefruit juice, because grapefruit juice does not play well with medications. It just really doesn't. And it's not that I'm, no slam on Grapefruit Farmers of America, you know, and it's not that I don't personally like grapefruit juice, but I don't take it with meds. It's just not good. So you want to avoid that. Carbamazepine, that's Tegretol. That's closely aligned with tricyclics. So you see people that are have some mental health issues who will also be on this drug, but it works well for seizures. Phenobarbital, I mean, it's a barbiturate. It's going to sedate the brain, and that's really how it works. Will it stop the seizures? Absolutely. Even a dog I had once, the poor thing had seizures, and they put her on phenobarb, and she slept 24 hours a day. So people don't like it because it really makes them groggy. Divalproax, this is Depakote, you know, that has a lot of uses in behavioral health. It restores the balance of neurotransmitters, which has a good effect for us using it for seizures, because if it's restoring balance, that's good. You know, it might not be for the bipolar patient who also takes it, but it might work here. Primidone is myceline. You know, that works. They all kind of work the same way, suppressing activity, restoring balance. The goal is we're trying to get the brain to quiet down. And if it's some imbalance, shift of something, we're trying to straighten that out. So, you know, Klonopin or Divalproax, ethosuximide, they're all kind of in that. I know you've seen them before. And the thing here is understand, if you've learned it once for behavioral health and you're saying, well, you know, Keppra suppresses activity, and so we give it to so-and-so and such, okay, take your knowledge of that and say, it's going to suppress seizure activity here. If there's irritability that tend to trip this person into having a seizure, that Keppra will suppress that. You know, so that's basically the concept of these meds. Because I know when you see these on the list, you're like, you know, look at all these meds, you know. All right, so the broad spectrum ones, gabapentin, I think I probably touched on already. GABA is inhibitory, right? Gamma aminobutyric acid. And so this is an analog of that. And so it's suppressing excitability. Lamictal, that's lamotrigine, that balances out activity in the brain. Topamax, decreased excitability. Keppra, we just talked about. Zonegran's a little different. Zonisamide, it's really a sulfonamide derivative. It's kind of a different action, but it works on the calcium and sodium shifting to change excitability. And Lyrica, you've all heard about on TV, you know, those commercials where they talk a million miles a minute about all the side effects and everything. Lyrica is out there for people with restless leg syndrome, and it's the same premise. Why? Because it's decreasing excitability. And so it's pregabalin, you know, the GABA is in here, the analog of GABA is in here, just like in gabapentin. So it's trying to decrease the excitability. And by doing that, won't let people feel like they have restless legs, they constantly have to move, or they have things crawling or whatever. So we're taking that and we're using it for that. And people say, I don't have restless leg syndrome. And you just say, that's right, you don't. But here's an interesting thing about pregabalin. And you talk to them about it, make them understand. All right, so in case anybody joined us late, I had mentioned before, since we had the issues trying to get on to Zoom and everything in the beginning, that I was just going to teach through. So by all means, it is being taped. By all means, if you need to get up and move around, go to the bathroom, have something to eat, whatever, please do. And I'm just going to keep going, so I'm sure we have all the content on tape. All right, so treatment regimens. Well, we've talked about a bunch of them, but let's revisit this status epilepticus again, because it's a mean one. This is bad. And so what are they going to do? I told you in the ED, first thing they'll do is go for the lorazepam, go for the diazepam, because it's going to stop this patient from outwardly jerking. But it's short acting. It's immediate use. It's not an anticonvulsant. So longer acting is probably what they'll go to when they admit them to the hospital. Take them off of these meds and say, let's put them on Dilantin, put them on phenobarb, put them on Zerontin or Lamictal or something. And then remember, the side effects for you, not only is this patient post-ictal, so they're zonked anyway, but then you have to watch how much of that might have been post-ictal and how much of that is related to dosing that we're giving them with the drug we're giving. The side effects, again, will be CNS. It's all your central nervous system, and we're decreasing excitability. It's going to decrease affect in a lot of people. So they can also have rashes. Don't forget to look at that. They can have blood dyscrasias, so we watch the labs. They can have liver and kidney issues. First pass effect for drugs that come into your body go through the liver for detoxification. From there, they're going to be excreted in urine. So if we have something that's not sitting right with this person, we're going to see a change in liver function tests or in their renal results. So we watch that. So phenytoin is probably the most commonly used, but let's look at some side effects of phenytoin. Gingival hyperplasia and hirsutism. So this picture here, where's my little cursor? This is gingival hyperplasia. And this is not a bad case. I've seen where it's all the way down here and the teeth are almost completely covered. Why? This is long-term use, and it's a side effect with long-term use. But I've seen it even worse than this because people have had such good control on Dilantin that when they see the doctor and they say, okay, you got to come off of that and you got to go to the dentist and have them laser off all this gum, and they don't want to come off the Dilantin because they remember the days when they were seizing and couldn't control it. And the Dilantin has given them that control. So they don't want to come off it. And so the doctor has to, and we help if they're in the hospital, and we say, look, they're going to start you on another drug, and as they take you off of Dilantin, you will be on these newer drugs, these that won't have this side effect. Now, some people, even on a newer drug, if they're not seizing, they want the Dilantin back. And so the doctor will say, okay, time has passed, you haven't had seizures, you fixed your gums, your teeth look great, your mouth is good, you know, you can go back on it if that's what you want. But if they get good coverage with the interim drugs, good coverage is the name of the game. So that's okay too. And it's all right for people to realize they don't have to go back to something that gave them the side effect. This is not bad. Sometimes it's all abscessed in here. I mean, their mouths can be a mess, but it's long-term use, and it's not everybody. This is a woman right here. So if it was a guy, we wouldn't care if he had facial hair, right? But this is a woman, and this is hirsutism, and it's not that bad. I've seen women with much worse than this from long-term Dilantin. So it just depends on your patient and the effect that Dilantin is going to have on them over the long term. But this is what we watch for. Okay, so surgical treatment. Well, above and beyond the ability to give them medication, there are still people who have refractory seizures. It's crazy. I mean, some poor people just suffer so badly from it. So what do? Well, number one, you have to be at a seizure center. And they do have surgeries they go to, but this is not, understand, not first line. This is way down the road when they have exhausted every kind of possible medical combination of drug they can think of to get you to a point where you won't seize. But they can, in the end, and I've had people who have had these done, and I know of people whose sisters or mothers had to go have this done, so it happens. But they can do an anterior lobe resection in the front of your brain. And they take probably 6%, maybe 4 centimeters, 6 centimeters of tissue alongside the amygdala, and they just take it out. If they find they can isolate that is the focus that's generating all your episodic seizures, they'll just take it out. So somebody really has to be pretty dire to go to that extreme to have a part of their brain taken out to be away from seizures. And it's usually somebody, I knew of the last case we got her after all that. She had it done at Duke and we had her down here for something else, but she had little kids she was trying to take care of. And the kids were found by themselves in the house and she was on the floor incontinent all the time. So, you know, she was desperate. She said, I'm either going to die like this or my kids will, God forbid something happens to them, or I have to do something. And they worked with her probably 4 years on different combinations and different things. And she said it didn't work. So she had it done. And her residual was not bad at all, but you know, it's a big step. I mean, she said she remembers going into surgery thinking, what am I going to be like coming out? Could I even care for my kids? I mean, you know, it's a big decision. So she did okay, but that's one of the things they can do. The other thing you may have heard about is a limbic or a corpus callosum resection. And I don't know if you remember back to your anatomy, but your corpus callosum comes up and both sides of your brain go off of it. And it's connected in the middle, not all the way up. When you look at a brain that's just doesn't have a skull around it, there's a hemisphere, there's like a split down the middle. So what they do is if they think both sides of the brain, because it's generalized seizures, are feeding this electrical anomaly, this excitability, they think if they can split some of that connection between your right and left hemisphere of your brain, they can lessen that. So this is a big brain surgery. They go into your brain and down through the top, they try and break some of that connected part, like split it up so there's less communication between both sides of the brain. And it does work in people. They're not doing it as, well, let's try this and see what happens. We've never worked on this before. I mean, it's been years and years of trials of this. And when it showed promise, it's something they offer, but not when you've had 2 seizures and say, I'm not dealing with this anymore. I want one of those hemispherectomies. That's not happening. This is really last-ditch effort at control. Okay, so what do they require of you? That it's confirmed epilepsy, that you have failed drug trials, multiple drug trials from what I have seen. They have tried every combination of drug. They've been all over these people, making sure their levels are good. They've been religious in taking them. They've documented all the cases of breakthrough seizures, et cetera. And that's what that's all about. So they have to have had multiple failed drug trials. And they have to feel they know the kind of seizure you're having, like where it's emanating from. All right, so other therapies, they've even tried vagal nerve stimulation. Now the vagus nerve is the longest one of the cranial nerves. And they just find that they can go in and again, instead of having, they can track it down and say, we think it's coming off of that vagus nerve because it's such a big one and it goes so far that if we just dull it a little bit, and they go in and do that, and it interrupts brainwave activity, and it's like a pacer. They put it in with a 10-year life and hope that it lasts you without seizure. Some people take with adjunct medication. Some people are off it. So, and the other thing out there that's really not recommended, it's balked in adult circles actually, is the ketogenic diet. When Atkins came out, like, oh, it's brand new, this ketogenic diet. Well, you know, we start seeing the influx of people in the ED who are in acidosis and are sick as dogs, and, you know, because they're not eating any carbs. But what they're doing here, it started with children. And they said people used to think that sugar caused kids to be hyperactive. That's before they knew better. And they would also think that hyperactivity in kids driven by sugar is what caused kids to have seizures. And that's not it. But the thinking came, well, let's take the complex carbohydrates out of the diet, because complex carbohydrates break down as simple sugars. So they figured the kids had all this extra sugar and that was causing seizures. So what they do is they take the complex carbohydrates out, and then your body, your liver has to rely on fat stores and fatty acids, break it down and use that for energy. And they were trying to track then, did people have less seizures? Well, it's not been proven in adults that they do, but it's out there, and there's natural groups and things like that that people say it's worth trying. When you look at medical research, there's not a lot of support for that. But it's in your Lewis, and it is out there, people talk about it, so we present it. Also, with regard to the impacts on anticoagulation, you have to watch, and most people are trying to diet and be on a keto diet, don't think about this because they're not thinking of problems like this. But with, you know, having decreased carbohydrates, they tend to have decreased intestinal flora, which then affects the amount of vitamin K they produce. So that can impact, you know, when they're on anticoagulants. And then it comes back to biofeedback. We're not suggesting anybody go for biofeedback and then they won't have seizures. We're suggesting if they're having auras and prodromes and are aware of it, go for biofeedback, and maybe you will discover you have them and you can identify them. That's where that comes from. Okay. So what do you do? If your patient is seizing, what are you going to do? Assess your patient. What preceded it? When did it occur? How long has it lasted? Can you see phases of what they're going through? Is there a loss of consciousness? Is there stiffening? Are they atonic? Are they, you know, what are they like afterwards? Are they confused or are they postictal? You know, Remember the safety. Think of the lady at the airport that nobody was thinking of, this poor woman caught with her hair in the escalator. Don't put anything in your patient's mouth. You couldn't get it in anyway if they're having a tonic-clonic. But that's like an old wives' tale. People thought that I don't know, your tongue would go in the back of your mouth or something. You all realize you have a frenulum that holds your tongue down, right? So it holds your tongue down. There's no way you can swallow your tongue. But it speaks to that whole, they thought people who seized were possessed because they frothed and they thought it was the devil and all that. So they just think they can swallow their own tongue or something. I don't know. But that's not true. And so we don't put anything in the patient's mouth. Protect their airway. Protect their head. How do we protect an airway in someone whose mouth is clamped shut and they're frothing like crazy? You get suction off the wall because they're going to hypersalivate. They can't swallow. And the body is in hyperdrive state electrically. So it's stimulating all these parotid glands to release saliva. And they're trying to get the body as it's shaking and all, you hear this, and they're filling up, it's bubbling over. And you're going to suction all that. Because when that seizure is over and the person takes a breath and they go, they're going to get all of that down in their lung. So we suction. You always have oxygen on the wall in a hospital. Throw oxygen on them. You can't give it to them by their mouth. I put an oxygen container on and put the prongs in. I would put if all I had was the tube and I don't have, for some, how you're in a room sometimes, they don't have what you need and you're like, a good nurse always improvises. If I had just the tube from the wall, from the O2 and nothing else, I would have it right by that patient's nose. We're trying to maximize the amount of oxygen in that airway. So when they take a breath, they're going to get it. Get rid of that saliva and use your O2, whatever you have. Okay. What else? Patient education, family education. Compliance is important. It's important with everything. And people are human beings, and humans are naturally non-compliant. So you got to get after them for that and support them when they're doing great. Wow, you're in for a gallbladder and you haven't had a seizure for 3 years on the treatment you're on now. Keep doing what you're doing. That's awesome. You've got to encourage them. They have to do their follow-up appointments. They have to watch for side effects and not just come off the drug if they don't like how they feel. Call the doctor, have a conversation, see what else you can be on instead. Tell the family if the seizure is unrelenting, even if it's not, even if it's 30 seconds and they think it's been 3 hours and they want to call 911, they're better off calling so the patient gets seen. We can better evaluate what's happening to them. Realize the difficulty. There is still stigma out there among people that think if someone's having seizures, they're possessed or they live a bad life or it's because they drink or what, people have these hangups. It's something that they think is, something they've done that's wrong and this is how they're getting punished and whatnot. So think about the stigma they live with. A lot of people can't keep a job if they've had breakthrough seizures because it's a risk for the place they're working. Once they see them fall and split their head or something, it's a risk. And risk management is going to say, this is too risky for you to be here in this environment. Driver's license after a seizure, it's usually 6 months you can't drive. It might be longer if you've had them more frequently. So, they really feel impacted. They should wear a medical alert bracelet. Some people don't like to do that because they don't want people knowing what's wrong with them. But it helps whoever's coming, who finds you seizing on the street, to look and see, even EMS coming has a clue. So we encourage that. And support groups probably help them. It's always easier. The old expression, misery welcomes company. If you're around people who truly understand what you're going through, it's helpful to you, then it's worth it, Okay, here's your nursing diagnoses: ineffective breathing, risk for injury, no big surprises here. All right, so brain tumors. I don't teach anything good, have you noticed? I teach nothing good. They're all horrible things to have. At least there's hope with seizures we can kind of maintain. All right, so brain tumors.
Unknown caller.
Oh my God, did I not shut this off a minute ago? I did I not? So brain tumors can affect anybody. I mean, there's young babies with it, there's old people with it. can get anybody. Men more than female, so we're taking that hormonal fluxing out of this equation. Caucasians tend to have a malignant brain tumor, whereas African Americans as a demographic tend to have benign tumors. We'll talk in a minute about both are going to kill you if we can't get them out. The mortality is the same. And brain is a very common site of metastasis. So you can have cancer somewhere else in your body and end up with it in your brain. So obviously it's abnormal cells. For some reason, they start growing erratically and you have abnormal cells. There is no room for this in your cranium. Your cranium has room for your brain and for blood and for CSF, and that's it. So when you have something starting to grow that doesn't belong there, it's not going to go well. So here is a scan. This is a rather sizable lesion. Let me get my cursor over here. This is a sizable lesion this person has. This is not newly diagnosed. I'm sure they've been in many, many times with knowledge of this, but you can see how it's encroaching in the ventricle already. So this person's in real trouble. They're probably pretty far gone, but the point is they probably couldn't get to it or couldn't collect all of it, or it was that mixed and heterogeneous that they just couldn't treat it well. But there's no room for it to go. That skull is not going to give. You're going to have increased intracranial pressure. You're going to have from cerebral edema that's caused by the tumor growing, and you have impaired blood flow. So you have ischemic issues as well. It's a terrible diagnosis for anybody to have. We do better with some of them than we do with others, but all right, so types. A brain tumor is considered a tumor that originates in the spinal cord or in the brain. So you can have spinal cord tumors and they're still going to list you as having brain tumors. The primary tumors, like primary anything, comes from the organ. So if it's a primary tumor, it originated in your brain. If it's secondary, you had a lung cancer, a breast cancer, a colon cancer, a kidney cancer, something, and it has now metastasized to your brain. That's the difference. Most brain tumors are metastatic. So if you've had it somewhere else and it's migrated there. All right, so more than half of brain tumors are malignant, which is not a good thing, but they're not real common, but it's not a good thing. They infiltrate and they cannot be removed. Like that picture I just showed you, that person's probably had it a long, long time. It was so spread across the back side of the brain and all, and then into the ventricles. I mean, it was big. And the scan didn't show any evidence that they had broken through the skull to do surgeries prior. So I think it's pretty far gone. But anyway, the primary tumors, you're not really going to see them going the other way. You don't get a brain tumor and then they say, oh, you have metastatic brain cancer to your colon or something. It doesn't go that way. It goes the other way. Cancers in the body go to the brain. And there's reasons for that. The meninges are the layers that cover your brain and spinal cord, and they're protective. And they don't allow stuff to shift through. But you also have the blood-brain barrier that you learned about. This is like a network of blood vessels. They are not fenestrated, so they don't have any openings to allow a lot to go through. Something has to be able to shift through the walls. They're these specialized endothelial cells, and they're right at the point where systemic blood meets with brain blood and brain tissue. And they don't let an awful lot through. Now they let glucose through. We know that can go through. So if you've dropped your blood sugar and you're going unconscious on me, I can give you a D50 up the IV and you come right to life. They let anesthetics go through. So, you, God forbid, have to have a surgery, we can give you anesthesia, it'll pass through and numb you for the whole procedure. Well, God knows alcohol passes through because we've probably all seen a person or two, not that you would have personal experience with that, but alcohol does indeed pass through. Lipid solubles do, so that something like propofol can go through, things like that, but not chemotherapy. We're not having a lot of luck with this, and it's probably a protective mechanism built into the brain when you're born. So it's, that impedes a lot of our ability to treat people. Unless treated, any kind of brain tumor, whether it is malignant or benign, is going to kill you. If we cannot get in and get it, if it's in a location we can't get down deep enough to get it, if it's because it's you know, attached to your base of your brain, or it's somewhere that you have too much blood involvement, too much vascular involvement. If we cannot get it to take it out, it's going to kill you. It's just the way brain tumors go. All right, so the primaries come up out of different tissues, so you'll hear people talk. Why do all these names mean anything to you? They may not if you don't work in neuro or you don't work in oncology. But just know that the names all attribute to something. So there's meningiomas and there's gliomas. Gliomas are, you know, a good number of brain tumors, probably mostly all malignant ones, a high number anyway. And so you hear them talked about a lot. But they'll say not everyone has a glioma. Somebody will have a meningioma. And so that's up out of the meninges. That's where it comes from. Somebody can have an acoustic neuroma. That's on your 8th cranial nerve, somewhere along the track. And it's, you know, it's from myelin sheath. They're usually benign. But again, we got to be able to get it out. And then we'll talk in endocrine about pituitary adenomas, which are very much a brain tumor. They are the dead center of your brain, but they're an endocrine gland. So we cover it under endocrine. But, and they are also typically benign, which is a good thing. But again, we got to get it out, you know. All right, so what do you see? Well, the symptoms are going to depend on the location. That's just the area of the brain it's going to affect. And so that's just the way it is. So what do you see? Well, a headache is very common. We talked about headaches last week. It's constant, it's dull, it's throbbing, it's worse at night because people, you know, in the day you're distracted, this and that. At night you're laying down, try to go to sleep, and it's throbbing and it's dull and it doesn't go away. You're not, you know, at one point taking Tylenol and, oh, it took it out. No, Tylenol's not going to touch it. Nothing's going to touch it because it's there. And the reason it's hurting you is the pressure it's applying to a space that cannot accommodate. Now, not all areas of the brain have pain responses, but at some point that mass will be big enough, it will affect some area where you will have a chronic, constant, dull, throbbing headache. It's difficult, you know, difficult. People do have seizures. Lewis tells us more with gliomas and metastatic disease than others. If you have a tumor that's affecting your brain, people can have a seizure, really, you'll see it. They can have cognitive dysfunction. Sometimes it's mood disorder. They're just suddenly angry and their whole affect has changed and it's headache driven and they're just miserable. And doctors will look into this to see what is causing this big change in your affect. Your mood, your memory, cognitive dysfunction. They can't find their way home. They can't tie a shoe. They can't, I mean, you know, it's a big change in someone. So I had a teacher actually when I was in my doctoral program, and we were 14 nurses in the class. Not a lot of people looking to put a fork in their eye and take a doctoral program, but we could see her confusion in class. I mean, it was really something. And she's a brilliant woman, and we were so glad we had her. She was, you know, a nursing theorist. She was great, but she was so confused and so bewildered. And so that we reached out, you know, we all had advisors and we reached out to advisors and they were working remotely because it was a distant program and they were in another city and they got in touch with her and she had lung cancer 3 years before and she had metastatic cancer to the brain. She was dead in 3 months. And they said, well, good thing she was in a class of all nurses. And we're like, no, it was horrible to watch, horrible to watch. But anyway, it's, you know, you see that it's a drastic change is my point. Muscle weakness, some people it's temperature alterations. We've had people come into Maine and the fever's up and the fever's down. They're like, oh, they're septic, they're not, they're this, they're that, and they're working them all up. And it's none of that. They have a brain tumor. And what it's affecting is the thermoregulatory center in the brain. That's where the pressure is. So there's a lot of differentials. You got to assess people well. And what I said in the beginning of the course about, of the lectures about how assessment has to mean something to you. What is the data telling you? You have to focus on that. And we'll talk about hydrocephalus or hydrocephalus, however you say it, that we can, you know, cause an increase of fluid in the brain and we have to manage that as well, right? Okay, so here's your areas of the brain and all this to say, you know, you have this already, I know, but you know, certain areas are more indicative of what's happening with your patient. So like here, if they're having word problems, the page before it said, you know, their expressive ability or whatever, how much I talked about it. The Broca's area, it's your intellect, but it's your word choice and your, you know, so they might go looking at that area if you have an issue there. And this is the only thing we're seeing. You know, if you kind of process what people are saying to you, Wernicke's is responsible for that area. It's your temporal lobe, and it's gonna, you know, the fact that I can say something to you and you can understand it and retain it and spit it back to me, that's your Wernicke's area. You know, it could be visual processing. You know, my father-in-law years ago had a stroke, and my mother-in-law called me in the middle of the night, and she said, well, he still can't see. And the thing was, what do you mean he still can't see? He was seeing fine. What do you mean still? Well, what she meant was at 1 o'clock in the morning, he woke up and said, Nina, I can't see. So she said, put the light on. You know, what would somebody who's married 40, 50 years say to the other half at 1 o'clock in the morning? So she said, put the light on. And he put the light on. He said, I still can't see. And she said, put your glasses on. Well, then he got tired and he went back to bed. And so now she's waking me at 2 o'clock in the morning or 2:30, and she's saying, he still can't see. And I said, what do you mean still? She said, well, an hour ago he couldn't see. I said, why didn't you get up and do something? I said, put him on the phone, you know? So I'm like, Dad, what's the matter? I can't see. I can't see. And I'm like, okay, I get off with her and I say, Ma, you got to call 911. You know, he sounds like he's having a stroke. And I'm thinking visual processing all the way over here. He can't see. And so I'm thinking he had a cerebellar stroke. So she said, but now he went to get up and go to the bathroom and his arm and his leg don't work. Well, maybe at 1 o'clock, it was just a cerebellar stroke. Now she's calling me for the first time at 2:30. Now I'm thinking he's having cerebellar as well because his motor control, his balance, he doesn't have it. So, you know, they don't want to call the ambulance because it makes noise in the night and all these things. Anyway, he went, he had the scans, the whole bit, and he did have 2 strokes, one cerebral, one cerebellar. So we can tell something. Is it speech? Is it words? Is it, you know, learning facts, understanding, processing? Is it visual? Is it, you know, what is it? Can give them an idea of what area of the brain we're looking at. Okay. So diagnostics, what are we doing here? Well, they do a H&P. Start at the beginning. It's good detective work. Physical exam, whatever they have, they'll do an MRI or a SPECT or a CT or a PET scan, you know, whatever's available, whatever they think is appropriate. It's not our decision. They can, if they find a tumor, want an angiography because it will map out all the vascularization that supplies blood to this tumor. And there's one medication we'll talk about that targets that vasculature. So maybe that becomes something we need. For the pituitary gland, we'll talk about an endocrine. We do endocrine studies for that. But we want a sample. If we can, we want to get in and get a sample. And now that we have stereotactic procedures, we can do stereotactic biopsies, which are very accurate and very, very little collateral damage. So what are the goals? Well, we want the tumor, and we want to know what type it is. We want minimal collateral damage. We want to manage the increased intracranial pressure, whatever's happening with this presence of this tumor. And surgery will reduce the size, and it will take down the ICP, and it will reduce the symptoms. Now, can it come back? Yes. Can you have mets from somewhere else if you've had another cancer? Yes. So they need follow-up, you know? But if we're going to go in and reduce the size and get these biopsies, what can we do? Well, we can do open or we can do stereotactic. So let's look. Open would be a craniotomy. So cranies are going to incise into the cranium. They do big burr holes first. They usually do them in like a squared area. They do burr holes on the corner. They take the saw from the ceiling and they make cuts in between so that they don't make puzzle pieces out of your cranium because they're going to try and put it back in. So they do that bone flap. They can go in with microscopes and drains and drills and all kinds of things and get what they try and get all of that out of your brain. It's a long, tedious surgery. I don't know how neurologists do it. God bless them. watching that kind of surgery. I mean, it can be 3 hours till they get to the place where they can begin to operate. It's long and tedious. All right, stereotactic, they put a frame on your head and they put you into an apparatus that locks this frame that's drilled into your head. It locks you into this machine. So if this patient starts seizing and all your head's going nowhere, and they can go in and drill in, and it's very specific. It's computer guided and it's very specific. They go into one spot that's been mapped out. They grab a sample. They can ablate. They can treat. They can, do whatever they have to do in there. And it's very little collateral damage. It may be damage the lobes they're going through to get where they're going, but as far as just going in and taking a chunk out and doing a lot more, broader area of damage, no. So now that we have these cyber knives and gamma knives and all of that, people are afraid of it. They think it sounds a little too Star Wars-y kind of for them to think it's going on in your brain, but it's very accurate. All right, so here's our cranie. So here's like the burr holes they do. They drill holes into the brain, and then they try and cut out all of whatever piece of your cranium they need. And they keep that piece in case they can put that flap back. If they know you have to take some time in between your surgeries and they're going to want to watch for response and whatnot, then they'll take you back up at a later day. They keep that piece of cranium. If for some reason the piece they cut out is around naturally occurring suture lines in your skull, you know how you just have all those funny seams, and it's broken and things like that, they can put an artificial plate in if they have to. This is your head that is screwed into a frame. This is drilled into your cranium, and here's the frame all around. And you're locked in a machine. You can't see it because the drape is over it here, but all that is locked. And then they can go in exactly to one spot and drill through and get what they need. And hopefully it gives them a lot. The patients, usually when we do stereotactic stuff, we try and keep them awake. And you may have seen films of it even. They'll say to someone, so tell me the names of your kids again, and they'll run down the family. Or tell me the months of the year, and they'll want them to say something. If they're in an area that affects recall, if they're in an area that affects motor ability, they'll say, let me see you pick your foot up and down. Let me see you move your right foot up and down, so that they can see what kind of collateral damage they're around in there, how you're responding. All right, collaborative care, ventricular shunts. This is what we do for hydrocephalus. And they put this catheter up into the ventricle of your brain. This is now under the skin. It doesn't look like it is here, but it's under your skin. They thread it down. They put it behind your ear under your skin, all the way down into the venous system and down, and they put it out into your peritoneum. And it's going to drain that extra fluid out of the center of your head so that you don't get ICP from it. You see it maintenance-wise with people who, like little people, people that have achondroplasia or something like that, and they tend to have a larger head and they tend to have hydrocephalus because the opening at the bottom of their head, their body is that different that it just doesn't drain well. And they have headaches and all the signs of ICP, and so they put a shunt in them as well. This would be for our brain tumor person. All right, if ICP is drained too fast, you're going to get headaches, you're going to get weakness. So we gradually raise the head of the bed, and it's usually by doctor order. Today can be 15 degrees, use the gatch in your bed, follow it. And make sure your families know you want to sit them up more, not today. This is the goal for today, we keep them here. You can have shunt malfunctions. Hopefully, if everyone's technique is good, we're not contaminating our patients. But if you get a systemic infection, they've just by putting an IV in and people aren't careful, or you put a Foley in and you're not careful, anything that has introduced bugs into this person's system is going to go for the new shunt site. Because whenever you have foreign material in the body, everything goes to it. Fibrinogen and white cells and everything goes to investigate it and say, this is foreign in the body. Do we want it here? What's it doing? And if you have a fresh operative site, it's nutritive. It's got good blood supply and all of that, collagen and everything. So bugs go there. And so you get an infection into your shunt, then you can have meningitis and die. You can have encephalitis and die. I mean, it's a really serious thing. So if they think they're showing signs of infection in the shunt, They take that shunt out, they give you an external ventricular drain, and you stay with that while they treat you and hopefully keep you alive and treat you for that infection, clean it up. When you're all clean of infection, all your cultures are clean, they'll go back in and put another ventricular shunt in.
Miss Jane,
Yes.
would these patients be on antibiotics prophylactically because of that?
They can't, not every day of their lives, no. But
Oh, okay.
if they suspect they have an issue, before they even go in to pull it out, they'll cover them, because they don't want to even be in and now be manipulating in the brain and the ventricles and all of that and not have something a little bit contained, so that you're not just having this massive spread, because they're going to be involved in blood and vessels and all of that, and they don't want to now get it into the blood. So they have it growing there instead of just being transported. So no, not just on a regular basis, no. But if they suspect that this person has fever or something like that, they want them on something. Let's mitigate this, try and get a hold of it, and culture it and see what we have and all that, put them on something. And while we're waiting on a culture to come back, yeah, they will do that. But it's where our technique has to be impeccable. Don't cut corners with people. It's not, this is where your integrity comes in, you know? And I know the desperate situations people are in. I've been busy at work, trust me. And people say, I don't have time, I don't have time. You always have time. I've had the worst emergencies in the world. And I say to people, I need this much sterile space, stay out of my space, either help or move away. I got to do it right. You know, the last thing this person needs is a urosepsis putting in a sloppy Foley on their way to have brain surgery. I mean, you know, you just got to keep to, it's not good enough. You know, people drop I've seen nurses do it. They drop the end of the IV tubing, they're going to switch into the bedclothes. And they pick it up and just hook it right in. And I'm like, and so I'll pull the student out of there and I'll say, what just happened in there? What is wrong with that picture? And she'll say, did you see her pick up that tubing and just hook it back in? I did. And you will erase that from your head. Don't ever, 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 ever do that. But sometimes in talking to the nurse, I'll say, I can't believe you just hooked that back up. You know, if I catch her in time, I'll say, please don't do that. I'll get you another tubing, and I go out and I do whatever. And she's like, no, some nurses will actually say to you, it's okay, the patient's on antibiotics. What, you know, like what microclass did that come from? Ever, said no one ever in their lives. I mean, this end of the tubing is in the bedclothes. We have no idea what's there. You realize that we match whatever infection the patient has, we match that bug with the drug that's going to kill it. And we don't just say, oh, any bugs anywhere else is okay. It's a big umbrella. It'll cover everything. No, that's not how that goes. You just can't have the sloppiness. You can't have that attitude that you're just going to hook something up that could contaminate somebody. So be very, very careful. After I was in ICU and I saw all the urosepsis that we got from just sloppy Foley insertions, it just, how somebody should die of urosepsis from that is just unconscionable. So be very, very careful of that, very careful. Okay, so what else? Radiation is something we can do. It's usually a follow-up treatment. They can also plant seeds, radiation seeds in the brain if they're in there. The problem is you put the seeds in and we don't have a little ring around them to say, just irradiate this area and don't spread anywhere else. So what you have is collateral damage. It's, you know, it's very controlled, the amount of radiation that's in them, but if they plant seeds in your brain tissue, we just don't know. All of these treatments cause cerebral edema because now we're putting seeds in that don't belong in the brain either, and the brain's none too happy about it. So we put them on high dose steroids. Dexamethasone is Decadron, glucocorticoids. So we put them on that to decrease that inflammation. Methylprednisone, anything methyl is absorbed well into the nervous system. Excuse me. So this is Solumedrol, would be a methylprednisone. I'm having an aspiration episode. Okay, stereotactic radiation we can do. And it's really kind of, you know, when people have seen it on people, it's kind of people that are so far gone, we can't do anything else, so we're going to give you this kind of radiation. It doesn't have to be, but that is a lot of times the condition. And what this is again, you're in the frame, and it's going to zero in on where that tumor is, And maybe it's deep down and we can't get to it. So what can we do for you? Let's zap it with this and see if it shrinks it, if it kills it off, if it does something. It might buy you time. It might buy you some quality of life. So the patient, again, is awake. Stereotactics, we tend to do that so we can see what's happening to you. And as they're zapping, they can say, you know, let me see you move your left arm. Let me see you smile. Let me see you do, you know, whatever area of the brain they're in, so they have something to go by. All right, so as far as chemo goes, I mentioned before we have limitations. You know, we have the blood-brain barrier. There's heterogeneity of tumors. It's not just you have this kind of cell that's a cancer in the brain, and that's it. And if we had something to kill that one kind of cell, you're good. They're heterogeneous. There's usually a mix of cells. So that's a problem. And then there's resistance. You know, there's the kind of cancers we have in the brain, there's just resistance. So what can we do? Sometimes they find that the type of malignancy you have and the location of it actually breaks down that blood-brain barrier. If, pardon me, I took a drink, now I'm belching on you. If they feel that that's the case, they're gonna try and give you some chemo because it just might get through and it might work. What can we give them? Nitrosoureas are usually what we use. They are alkylating agents, and so they inhibit DNA repair, and so that can usually take them out, we hope. What else? We can do implanted wafers. They have what's called a gliadel wafer, and it looks kind of, I don't know, students tell me they picture a communion wafer. It's not like that. It's bigger. It's more gauzy, kind of porous, you know, and they're round. You can cut them to different sizes. But if they go in and they excise, let's say, a tumor, and they go in with one of those scoopers, kind of ice cream-like, and they scoop this thing out, they can do whatever they can to get the most they can get. And then they lay this impregnated wafer down with chemotherapy on it. Now, again, you can line the hole that they've just created with this wafer, but does it stop there? Does it say, well, I won't seep a little bit over there into that section because I won't do that. That's not where the tumor was. No, it has no mind to do that. So it's going to seep wherever it seeps. So the control, again, like the radium seeds, how much is going where, we don't know. But it's what we have. The other thing they use is what you see here. This is an Ommaya reservoir. You know, you design something in medicine, they put your name on it. So this Ommaya here, this Ommaya reservoir, it's a little capsule up here with silicon top. And all of this is threaded down into the ventricle. Excuse me, I'm choking to death. Okay, so this is down into the ventricle. Now, we can give chemo through that if it's helpful. We can also take samples through that. We can do any number of things. I mean, we can get into this Ommaya reservoir and just, you know, this was a great finding. We can take CSF samples and see if you're growing bugs. We can, now, mind you, this goes directly into your ventricle here. So if whoever is handling this syringe is not cleaning that skin off well and is being sloppy, they're going to cross-contaminate this reservoir that goes right into your ventricle. And you're going to have a horrible infection that will likely kill you. So you have to be very careful in your management and treatment of them. But it was a big breakthrough when we had it, when it came along. It was a big thing. All right, what else? Oral and targeted therapy. Temozolomide came along and everybody was excited because it was the first one that we knew crossed the blood-brain barrier, and it did not interact negatively with seizure meds, and it would play nicely with antiemetics, which are a big thing for people with brain tumors. And it was great, but like a lot of chemos, it causes myelosuppression. So, okay, it does all those other things. So they use it, but then they have to watch your blood cell counts because it's affecting your bone marrow. Then there's targeted therapy I referred to before. So bevacizumab we use, this is Avastin, we use this for many things, many other cancers. And what's good about it is it targets the endothelial growth factor. So there was a way to look at the vasculature, and if we give them this chemo, it will kill off the vasculature that supplies the tumor. Now, we still want to be able to get the tumor out, but if this helps with treatment to at least not let it grow because it can't get blood supply, that's a huge thing, you know? You see it used if you've ever been on oncology floors or you tech somewhere or you know someone who's had cancer issues. They They use it for lung and ovarian and colorectal cancers, kidney cancers. So Avastin has been around, and it's, it has good results. So we're happy that we can use it there if we can get it to work for the patient. So in spite of the things they for every step ahead they go, there's restrictions because they're dealing with the brain. And there's only one of them. So, we have to be careful. They're working in research on an Optune thing, which is kind of this wacky thing, but it deals with the electromagnetic fields in the brain after you've had a surgery or after you've had treatment to see if you're having recurrence. So there's hope for more things out there. Bright minds working on things. So what do? You're the nurse. Assess your patient, Glasgow Coma Scale, level of consciousness. What were their motor abilities? What are they now? What's their balance, proprioception? What is it now? What's their pain response? What's their sensory feeling? What's their bowel and bladder function? How's the increased intracranial pressure? What are the signs of this we're looking for? You got to watch them for it. What will you see with increased intracranial pressure? Headache. A change in level of consciousness is important. That's a great NCLEX question. Change in level of consciousness is reportable. It's indicative of trouble. When I talk cardiac, I talk about it. Change in level of consciousness. Ocular changes. Remember, I told you that oculomotor nerve exits the cranium very close to the surface of the brain. So when there's any kind of swelling, we see a change in the pupillary reaction. So a change in pupillary reaction is reportable. Not that, gee, when the lights are on, they're at how many millimeters. When the lights are off, it's much, that's a combination. But if somebody with a neuro issue had equal pupils and now they're not, or they always were at one size and now it's not, it's reportable. Vomiting, look for vomiting. Pressure on the brain is going to give them vomiting. So, and what is their motor function? Is there paralysis? Is there ataxia? God forbid, they're decerebrate or decorticate. So you have to watch all of that. It takes a lot of assessment. What else do you do? Pre-op teaching, we do not encourage people to cough and Valsalva. We don't, because it's going to increase intracranial pressure postoperatively. Now, we're going to give them the incentive spirometer, we're going to do all of that, but we don't want them pushing to poo, and we don't want them coughing and taking, doing any of that. If your patient is nauseous at all post-op, treat the nausea so they don't vomit. It decreases, vomiting is dangerous. It increases your risk of aspiration. And in this case, it's going to increase your intracranial pressure. Prepare the family that the patient will be in ICU and what they can expect to see, not just the noises and all of that, but the equipment and why it's necessary and why they would rather the patient be there than anywhere else. Talk to the patient, tell them how their head will be shaved. They try very carefully to just shave the area they need, not like years ago, they used to shave your whole head. They just shave the area they need. But God forbid it was me, I would say, take I don't want infection, take what you need to take, and then a little margin more, because I don't want, hair is filthy. I don't want it anywhere near my incision site. What else? Ensure the spiritual support. We don't just say we take holistic care of people, we take holistic care of people. And it doesn't matter what their faith is. If it's their faith, we're going to get somebody in here to help them. I had patients in New York who were Zoroastrian. I had never heard of it. Call the chaplain. He's like, yes, I can get you. Of course, New York, they have something of everything. Yes, I can get you something. And the guy was there in an hour. But why should that patient have to face anything, dying or surgery or anything, without their spiritual support like anybody else would need? So be sure your care is holistic and you're meeting all the needs of your patient. That's a big thing. People are frightened. They don't know if they're going to survive. It's hard to face your own mortality. All right, so you're not done yet. Assess your patient. Frequent vital signs and neurosigns, and they're not perfunctory. Don't make them mechanical. I have to do vital signs. You go in and do them, they're done. Stop and look at them. What is it telling you? Compare it to the one before. How is it changing? What's happening? You got to be proactive in critical care so that you're not reactive. Check the dressings. Someone with a cranial dressing, it's like someone with any kind of neck dressing or anything. If they're sitting back, the blood will go that way, down to the back. And so you're looking at the front of the head saying, no, dressing's dry in the attack. Move that patient, turn them over so you can see. So the blood is not pooling in the back and running down their spine. I mean, you have to look at people to see what's happening. Watch the intracranial pressures, fluid and electrolytes. You'll have a ton of labs post-op. Nausea post-op. Now, ICP in itself might not give them nausea, but anesthesia will. So if they've had anesthesia for their surgery, they can wake up. Don't tell yourself, oh no, ICP doesn't usually have nausea. They just vomit. This patient's nauseous. So treat the nausea because we don't want them vomiting, okay? Careful pain control. The cranium doesn't have nerve endings, so they usually don't feel that. And there's only certain parts of the brain that do feel pain, have pain receptors. And the doctors, whatever they give them, they know that. They're neurologists, God love them. So, you know, don't sit there and say, they're not giving them any, you know, Dilaudid or any this or that or the other thing. Look at what's there and understand the mode of treatment, why it's appropriate. Head of the bed is according to directives. Each patient is going to be a little variant. If there's no bone flap, if they took that flap out and they kept it out because they know they're going to have to go back in again, or it's all broken and they're going to put another artificial one in, there'll be a big divot in this patient's head. You can't believe how much shape your cranium gives your head. So without that piece, it's going to look like it's sunken. You have to protect that piece of the brain. You know, people are overhead changing IV bags and whatnot. Don't drop anything on this head. It's not protected if there's no cranium replaced. So be very careful of that. Support the family. And don't forget there's a patient under there. I talk to my patients every time I'm in the room. Every time I'm in the room. And I tell them what I'm doing, and I tell them who I am, and I have my hands on them so they know I'm there and I care about them. But also, as I go along, I tell them what I did, what I'm doing, what, you know, I tell them all kinds of things. I'm in there with students, and I'll tell them I'm here with my student, you're fine. I'm just going over some things here so she can learn about this. And then I say, so my student's almost ready to graduate. I tell them all about it. And people are laughing at me, but I'm telling you, nurses aren't. Because when you've seen someone come out of a coma and they can recall everything you've said to them when they were out, it's impactful to you. And you realize what it must be like to be locked in like that and have no one say anything and not know what's going on. So talk to your people. They need to know there's a lifeline there. Talk to them. All right. What else? Nursing diagnoses, acute pain, self-care, anxiety for sure if they're going to have brain surgery. And our goal, we have to maintain normal ICP. Don't have them come through a brain surgery and then die because they herniate their brain from ICP. I mean, they had a prayer of living, let's let them live here, you know? Maximize their neural functioning, control what pain they have, and help them with long-term planning. There might be a lot of adaptations they have to make. So they need help with that, all right? So I thank you for being so patient, letting me go over a little bit, letting me continue to talk. But I wanted to be sure the whole tape was here. And this way, I'll set it to convert. Last time it took a long time to convert. Hopefully it won't take this long, but I'll set it to convert and I'll post it as soon as it's ready. Okay? All right, guys, I will see you tomorrow for liver is tomorrow. Yeah, liver's tomorrow.
Miss Jane?
Yes.
Can I ask you a question? If your patient had